Okay, good morning, everybody. Thank you, as always, for joining us. And as usual, we'll give it a minute for people to join in. And as usual, we have a couple updates for you. Dr. Collins will start first to talk about census and also talk a little bit about occupational health as Dr. Brian Bowman is in another meeting today. Dr. Collins, I'll let you throw your slides up.
Okay, can everybody see?
Yep, thank you.
So I'm going to update just quickly in terms of the status of COVID-19 here and nationally. Let me make sure that, oh, there we go. So as we all, I think, know, there's been quite a surge in cases in the country. This is data from New York Times and the Atlantic COVID Tracking Project. You can see what looks like basically exponential growth in cases and hospitalizations in the country. And then looking locally, we talked a little bit about some of these blips here at the end, but it does seem like we're having more of a trend towards increased hospitalizations in our local area too. So that purple line is Santa Clara County. You can see several other of our local counties. The San Mateo line is still not coming up, but we'll have to wait and see in terms of where that goes. Looking at it also in terms of reopening, you can see this was October 27th, and yellow is best, then orange, then red, then purple. And this is now yesterday. So Contra Costa and Santa Cruz County have gone back. San Francisco, even though it's still yellow, has announced some reversing of reopening. So certainly rates in the area are starting to go up. Looking at our own cases, excuse me, I got a kid who's waking up in the background, but we'll try to finish quickly. Our positive cases haven't necessarily gone up. That's the top left, although the last week you can see a little bit of an uptrend. Hospitalizations, I'm showing it both as new hospitalizations by week and as our midnight census there, that kind of more jagged line at the bottom. Two ways to see it, but it doesn't seem like we've necessarily seen a big upswing here at Stanford yet, but certainly something we have to be aware of. Our census as of last night was 11, with 3 in the ICU, 1 in the ED. Our demographics are essentially the same. The numbers have gone up, but for the most part, the trends are the same. So you can see we have a slight female predominance, although a slight male predominance in deaths. And then particularly with race ethnicity, that's still quite weighted towards folks who are Latinx background. I'm going to also present Brian's slides. He unfortunately couldn't be here. And the main take home here is that in the last week, we've had a spike in new employee cases as well. So 28 cases, which I think it was 13 the week before. That is something that he's been particularly concerned about. And actually in the July timeframe, which was our surge so far, we were at like 30 to 34. So it's not that far from some of the surge numbers in terms of employee cases. This is his summary slide and basically making the point again that there are surges in the country and that it's starting to seem like we may be moving into a time when the Bay Area, as he said, our bubble may be bursting. So cases do seem to be on the rise locally. And he did also make the point that when they did contact tracing on those employee cases, that it did seem like this was not transmission at work, this was transmission outside of work. So social interactions outside of work in particular. So just a reminder that you have to wear your mask, not just at work, that you have to be conscious of social distancing and staying safe throughout everything. Hopefully it'll be an okay winter for everyone. Excuse me, okay winter for everyone, but definitely some signs that things may be increasing in the area. So thank you to those folks who helped me with gathering this data, and I'll get back to our main presentation.
Thanks, Dr. Collins. Just to hit that home again, Dr. Bowman, and thank you for sharing that. Wanted to make it clear that these infections seem to be not related to employee infections, but just really us just getting infected in the community and getting tested here. We'll have more on that. Dr. Bowman will be back next week to present more as well. And if you have any questions regarding occupational health, please still send them in, and Dr. Bowman will help answer them and we'll get them out to you, or we'll have someone on the panelist team try to answer it now. Dr. Mahoney, thanks so much for joining us this morning. I think, can you see your slides up there?
Yeah, I can. Thank you so much for sharing them. Thanks, Sarah. And thanks, Dr. Collins, for reviewing those numbers. Just to build off of that, this possible sustained uptick in the COVID infections among healthcare workers, I just wanted to make sure, I'm sure a lot of people are already aware that Stanford Healthcare has introduced a COVID safety campaign to remind medical staff and other frontline providers that we are essential in supporting the safety and well-being of each other, and then also of our patients and the care delivery system. And so the campaign has three different components. So one is to be safe and continue our vigilance by using PPE and observing social distancing and encouraging adherence among our patients, visitors, and coworkers. Also to be smart and stay educated by attending activities like the Grand Rounds this morning. And then finally, as our CMO Neeraj Sehgal will always stress, to be kind with each other when interacting around these issues with our patients, visitors, and colleagues. I heard Marissa Holubar wisely say recently that testing is only good for the day that it was obtained. So I appreciate your engagement and all the engagement you already have provided and will continue to provide to support our colleagues, patients, and visitors to adhere to safe practices. And so on the next slide is just a brief reminder of how to self-schedule as we start rolling into the holiday season. I know most of us are planning to stay home given the circumstances, but if you are interested in traveling and are planning those travel plans, it's just nice to be reminded that it's very easy to obtain testing. You can self-schedule through phone or through the MyHealth app, and it's just an excellent resource as we start approaching the holiday season. And then finally, on the last slide, is just a quick reminder that today at 5 o'clock, the medical staff office will be hosting a town hall and are very grateful, fortunate to have our very own Kevin Schulman present a health policy outlook. And we'll touch on COVID, the Biden presidency, and ACA. And the Zoom connection is provided here, but also you should have received an email yesterday with that information. So hopefully I'll see you then. And those are all the updates for today. So thanks, Errol.
Thanks so much, Dr. Mahoney. That's really great. Awesome. Looking forward to hearing you speak later today, Dr. Schulman, Kevin. And before I introduce our next speaker, I just want to briefly mention that we do next week have Dr. Barron, who's the president and CEO of the American Board of Internal Medicine, ABIM, and he's going to talk about the mistrust in healthcare. We have no grand rounds the day before Thanksgiving, and then we have Dr. Ed Damrose talking about his experience COVID-19 when he was deployed to Guam earlier this year. And speaking of travel, Dr. Mahoney just mentioned, we have a Dr. Lynn Chen. She's the associate professor of medicine, really the president of the International Society of Traveling and medical travel. So she's going to be talking about traveling just in time for the holidays in case anybody is planning to travel. So looking forward to those future grand rounds. But talking about looking forward to grand rounds, today we have Mr. David Weiss, who's going to be talking about the bubble that was created for the NBA. Mr. Weiss graduated at Dartmouth College back in 2002, got his law degree in 2008 from the University of Michigan, and really quite an interesting experience history he's had since then, included working for a congressman for the U.S. House of Representatives. He was working at the appeals court, the Ninth Circuit, as a law clerk. Multiple things. I won't go through every one. He did the law clerk for which I won't hold against him, for the Oakland Raiders, not the 49ers, but still pretty cool. And so David Weiss has been with the NBA for over the last 8 years. He's been the vice president and assistant general counsel. He's currently the senior vice president of Player Matters. And he's going to be talking about, as he has this topic here, creating the bubble for the NBA. He's worked with a couple faculty members, at least a couple from Stanford, including Kevin Schulman, who thank you, Dr. Schulman, for connecting us with David about this presentation, and Dean Winslow. We'll both hear, I think, from them a little bit later today as well. But David, thank you so much for being with us. I'm going to ask Talia, I'm going to stop sharing your slides now. These slides now. I'm going to ask Talia to, or actually, you're going to be sharing your slides. I'm going to ask you to start sharing those. The last thing I'll just say, and I think most people know this, have read any news articles about the NBA, is one of the probably with the crazy year we've had a few positive storylines, and one of those big ones was the NBA's ability to create this bubble and successfully not have a single player, staff at all get infected, which is unbelievable. He's going to talk more about that. So congratulations, I'll just say, David, on just a huge accomplishment. And thank you so much for taking the time for being with us here today.
Yeah, thanks, Errol. Thanks for having me. Before I start, are you able to see my screen?
Looks great.
Great. So happy Veterans Day to everybody. To Dean Winslow, who's on the call, who's an advisor to us. Thanks for your service, and for all the other vets online. Thanks for Kevin Schulman for inviting me here today, and thanks for really everyone at the hospital for being on the front lines of the entire COVID response, which has been going on for quite some time now. So I should say, as Errol did at the top, my background's not medical. I'm a lawyer by training, but in my role at the league for the last 8 years, have been working, managing our health group, which is really a mixed operational, medical, legal group, working with a lot of physicians, PhDs on cardiac screening, concussion, electronic medical records, injury analytics, things like that. Have a research program, work with Gary Gold at Stanford, looking at natural history of articular cartilage injury, and so a lot of other things. But since since the beginning of this year, really have unfortunately been mostly on COVID. So that's what I'm here to talk about today, and the NBA bubble, as it's referred to. So for those of you, I'll start with a timeline, just for those of you who aren't as familiar with the league, which I'm sure is some of you. So we started really in January. The end of January is when we sent our first memo to teams on COVID. We have offices in China and several, and we're seeing impacts there, and it's something we started paying attention to. And we've had a robust infectious disease operation for some time, really dating back to Magic Johnson and HIV/AIDS, when we started working with Dr. David Ho at Columbia, who you'll see in a minute. We're still working with, and has been one of our key advisors here. And then more recently, USA Basketball playing in the Rio Olympics when Zika was there, or in West Africa when there were Ebola issues. So a history of working with the CDC and on infectious disease issues. And so really from that January to March period, we sent teams actually dozens of memos as the situation became increasingly urgent, working with Dr. Ho, also Vivek Murthy, who is a close advisor to the league from a public health standpoint. Obviously, he's been in the news recently for being on the new coronavirus task force. So had our first positive test March 11th, and suspended the league that night. We had been doing a lot of work, of course, before that, and sort of knew at that point, thanks to that good advice we were getting from an infectious disease and public health standpoint, that we really didn't have a choice if we had a positive test. That's, some people have remarked that was the same day that Tom Hanks announced his positive test, and that I think the combination of the NBA and Tom Hanks made COVID a little bit more real for a lot of people around the country, and to the extent we played a small part there, we're happy, such as it is, to do that. And so really from March to May, like most everyone else, except for I suppose essential workers, we were shuttered, we were quarantined at home, and trying to think about how we may return, working closely with a group of medical advisors at that time, and really started to come up with this bubble plan, which sounded fantastical at first, and then less so as we got into it, and just the idea that we weren't going to have a handle on this virus for some time, and that with regular testing, which we knew we would have to wait on for more broad-based availability, that there would be a way that PCR testing was sensitive enough to certainly snuff out infections before they spread widely, and potentially before people became infectious if you did them regularly. Talking to Dr. Ho, his view and other views at that point were that unfortunately the virus, fortunately it doesn't do much in tissue culture for about 24 hours, but then it replicates quickly. So that's an inconvenient truth, I think, for testing programs and surveillance programs. So we knew we'd have to do regular testing. In early May, we, for the first time, sort of activated again, opened our practice facilities in a very limited way that seemed, like a big step at the time, where the country was in early May. The rules then were only one player, one coach on one basket in a practice facility at a time. So incredible, physical distancing and masking, and worked with a lot of local governments there. May 22nd, when we announced that we were, going forward with Disney, did a press conference in a landscaping parking lot. Not really, we just did a press release, and then June 16th, that's when, and I think really you can see here how compressed this time frame was. June 16th, we issued a 113-page document of health and safety protocols that reflected medical advice, was negotiated very closely with our Players Association, who are incredible partners in this along the way. And then in late June into July, we had a ramp up where players came in June 22nd, had a week where they didn't come in the facility, they were just in team markets, they got tested every day. July 1st had required individual workouts where everybody came and did that one player, one coach, one basket model. That's when myself and a lot of other people started getting down to Orlando. The teams traveled down to Orlando July 7th, 8th, and 9th. And we're there for a few weeks to get reconditioned. Everyone got sort of deconditioned, and COVID's obviously the main health issue we were dealing with, but wanted to make sure we didn't have a rash of orthopedic injuries, and so had to get through that, and then got into the season into July, which just finished in October, obviously with the brief but important pause around social justice issues. So that was our timeline, and I want to focus for a minute. This is the medical and health group that advised us here, and I think it's important to show this was not the case of us finding one infectious disease physician and working with him or her. I mean, it really takes to do what we were doing, and I think to think about big organizations to have comprehensive COVID plans, expertise across a lot of areas, and so whether that's obviously infectious disease, but subspecialties for virology, for epidemiology, for infection prevention, our regular sports medicine group, public health. You'll see here mental health, a psychologist. We had psychologists in the bubble, as we knew this would be a trying time for people to be away from their families, like they were for long periods of time. Pathology to focus on the lab operations. So really broad-based, and of course for this group the most important thing is Dr. Winslow, who's at Stanford. So appreciated his work. He really advised us throughout on our protocols as we put those together. So a broad-based health team there. Just to give you a little bit of overview of what the bubble was, it was essentially three hotels and a 3-court 3-venue basketball setup, and so all of these hotels were sort of separated from the rest of the world, such as it was, with sort of perimeters where people kind of knew who was coming and going. Obviously, it's a free country; everyone could leave whenever they wanted. But the point is, if they left, there were kind of strict reentry protocols, quarantines, and things like that made it such that it wasn't really desirable to leave. People came voluntarily. Some players, staff did opt out of coming. It just wasn't for them. But the people who were there were really bought in, and I think that was critical and speaks to probably things that you deal with in the health system, is just how important it is to have everyone bought in from medical, nurses, custodial, everything down the line to really be rowing on the same oar. So this was the campus setup. I'm sorry, and then really the protocols that we're operating under, again, like I said, is 113 pages. There's a lot there, and people who do infection prevention obviously know that the rigor and the detail that involves. I've since learned, but really there were some basic principles here. An arrival quarantine, so that when people were coming, they had to do an in-room quarantine for 2 days. This is after a few weeks of testing, but had to do an in-room quarantine of 2 days. Clear 2 negative tests before they were allowed sort of out into the bubble. Initially, people who came in later had much longer arrival quarantines, 4 to 7 days. Of course, distancing, masking, daily testing for those who were living on the campus. There were also literally thousands of people who were supporting the campus but not living on the campus who were tested less frequently. So think Disney hotel workers, food service, housekeeping, bus drivers, livery drivers, people from Advent Health who were doing temperature checks. So it wasn't practical to test all of those people every day. They weren't living on the campus, but they were tested several times a week to try to make sure we didn't have significant kind of potential super spreaders. Sleeping rooms, individuals couldn't go in each other's rooms, and then cleaning and hygiene. Disney had incredibly rigorous cleaning and disinfection protocols, and those were documented all over food service, the arenas, the hotels, and they had been doing a lot of that work, and then we worked with them to really bring it to the next level for this kind of event. So I'm going to pause there, Errol. I'm going to ask you to show. We have just a quick video that we showed to players and staff who are arriving, and I think this all seemed so foreign at the time to people. It in retrospect doesn't seem as foreign, but it seemed incredibly foreign at the time. And I'm just going to show about 2 minutes of this 4-minute video, and I'll also say that it really was one of many, many, many public health efforts that we had with our sort of defined population. So, door hangers, texts, apps, trainings people had to do, videos, regular meetings, and the really, we have some people with a public health background in my group who really put together a strong education program, and just that constant reminder. We found, obviously, people got tired of it, so then we'd switch to text, and then they would get tired of the text and we'd switch back to videos. And just thinking about those broad-based approaches to how we really educated our own staff and kept them vigilant was important. But this is just an example of a video that we put together for people prior to arrival that will give you a sense of how some of it worked, and we'll show about 2 minutes of it.
To minimize exposure with the public, you will arrive in Orlando by charter bus or plane. Those arriving on planes won't enter a public terminal in Orlando. Physical distancing is a key safety protocol, so please don't sit next to each other while traveling. Teams will be assigned to one of 3 deluxe hotels on the Disney campus. Each hotel has been outfitted to keep your safety the top priority. Upon arrival at the hotel, you'll receive your Magic Band, a no-touch room and access key, and get an initial coronavirus test. In your room, you'll find cloth and disposable masks and a number of other items to keep you safe. Sanitizing is key to our protocol. Your luggage has been carefully handled, but we recommend you clean and disinfect your personal items after arriving in your room and throughout your stay. In-room quarantine for all team staff and players will last for approximately 36 hours to allow for the results of 2 coronavirus tests to come back negative. Stay inside your room for the duration of the quarantine period. Your meals will be delivered directly to your room. To minimize interaction with others, we won't have house cleaning during this time. Coronavirus testing will be done in your room by a test collector wearing personal protective equipment. During quarantine, you'll have trainings and orientations to get prepared to play. As you move about the Disney campus, please adhere to the following guidelines. Participate in daily coronavirus testing and health monitoring procedures. Engage in strict physical distancing and use of face coverings. Follow strict hand and respiratory hygiene. Reduce use of shared objects. Do not enter another person's sleeping room. Follow rigorous cleaning and disinfection procedures. We've developed a comprehensive medical program which includes daily testing, temperature checks, symptom screens, and more. These requirements will be registered on your Disney Magic Band, so when you've completed your requirements, you'll be able to pass through campus health checkpoints and participate in team activities on and off the court.
That's great, Errol. We can stop there. I think everyone gets the idea. So just again, an example of public health messaging. It almost looks kind of quaint now, sitting here in November, but when we put that together in June, it felt like we were really trying to figure out, what was going on. I think we can talk about more. I think our thoughts about temperature checks have changed since then. Certainly, surface versus aerosolized transmission. I think we had an idea of that in the summer, but more so now. So just an example of that kind of public health messaging that was so important, I think, to the success and the real buy-in from everybody there. Going back to my screen, also wanted to talk about, certainly for this group, in addition to COVID, there was a significant medical clinic on campus. Dr. Leroy Sims, directed this effort. So this was, partnership with Advent Health in Orlando, and X-ray. We had MRI, CT. Kind of full service clinic that we had to set up within the bubble, and then the Advent staff who would come in were tested. As you can imagine, when you finish a significant part of a basketball season and you have 1,500 people or more living on a campus, you just have a lot of things come up. So that was what was available there. Mental health and wellness services as well. And then we had to create a whole series of protocols around what we called a clean corridor. So despite having this clinic, some things that needed to get done still at the hospital, minor procedures, even a root canal. Minor things like that where people had to leave, and there was a lot of preparation for, okay, if they have, if we try to do appointments Monday mornings, we can get a small amount of staff tested, we can get them in an office, out through specific entrances, and kind of documenting all of that with our infection prevention physician who we worked with at Johns Hopkins. There's a lot of work around that. So a big medical effort there as well. I should say one of the biggest challenges we had was this was all happening in, I think it's apropos for what we're experiencing now in an environment that we couldn't have imagined when we planned it. I think in working with our epidemiologists that we were speaking with them in May and June, we knew that there was going to be more cases in July, because it was just the nature of people moving around more. I think fairly we didn't predict the degree to which there would have been more cases in Florida, and the fact that it peaked almost simultaneously when we were arriving. And so this is the daily new cases in Orange County, Florida. You can see kind of the line there in May and June, and then really rocketing up in July. You overlay that on our timeline again, and so the numbers here, the first number in red before those slashes is Orange County. The second number, daily new cases average 7 days, and then the second number is in the state of Florida. So you can really see the timing was not great for us. And I think one of the things to take away from this is that the testing, obviously the testing was critical in identifying if we'd had spread, which thankfully we didn't, and in making sure that people in the community who were coming in, who we absolutely had positive cases among them, meaningful number, which we'll talk about in a minute, that we were able to flag them and have them not come work for several days in this bubble. But I think it also speaks to just masking, distancing, and constant education on those topics, how much that can, the testing reveals the spread, and it's really the protocols that prevent it. So we sort of weathered this storm now, and it gives us some hope for what's obviously a tough situation that we're in across the country now. So want to talk a little bit you saw some of the things there. So just how this actually kind of worked in practice from a medical monitoring standpoint. So everyone had an app. There's an app for everything, so everyone had an app, and it was sort of the integrative glue between some of the daily screening and testing we were doing and access around the campus. And so the PCR test results, a daily symptom questionnaire that everyone had to fill out, a daily in-room temp check that everyone did that was connected, with a Bluetooth thermometer to the app. The same for a pulse oximeter, and then as part of it, was really part of the survey was COVID exposure. That all went into this app. If all of those things were done in the requisite time period, that created a green status, which translated to you being able to swipe. Everyone wore these magic bands to swipe green, which is showing in the picture there as you walked through an area. And if you didn't have a green status on the app, if any of those components were missing, it registered a different color. And those magic band points were set up at all the arenas, at all the entrances to all the hotels. You had to walk by them when you got on and off buses to go between hotels or to the arena. And so that was really, one of the compliance mechanisms we had to make sure that people were all actually doing these things. And that's, I think, a huge lesson too, is we underestimated going in how much time we'd really have to spend on compliance. We figured, well, we're making, testing available to people. Everyone wants that. It'll be well received. And by 95% of people it was, but people get busy. Some people just like it less. Some people don't like filling out their app. And so having to track the compliance with that, both, back end from a software perspective, but also kind of these real world checkpoints was really meaningful. And I know as we think about, translating that into a more normal setting in like our offices, for example, thinking about compliance, and that's something we could talk about more, but how all of these things translate into a more replicable setting. We're certainly cognizant and self-aware that this is not replicable in a lot of environments, even for us, again, potentially. And so, taking lessons from this, rather than porting this whole model over itself, I think is a key piece there. On testing, we always get a lot of questions about testing. These are just pictures of the testing rooms. They're not so exciting, but that's what they looked like. And just speaking to all the things you have to think through when you're hosting 1,500 people for 3 months. So this is then the pediatric testing room, and so players and some team staff were able to have once we cut in half the number of teams there. Once our playoffs advanced, players and team staff were able to have guests join them. There was a whole arrival quarantine involved in that. And then we had children there. So then we had a pediatric testing room, and we spent a lot of time on protocols for kids with pediatricians, pediatric infectious disease. Did we need to test everybody down to every age? We decided we did. It seemed like even over the course of the summer, there was increasing evidence of the risk of spread among children. So even there were some infants who were there, people who, a few players whose wives had recently had babies. They decided they wanted to bring them there. So those they were even swabbed every day. So really sticking to that. So then just a little bit more, again, because I know people are interested in it, on testing. So this is kind of a summary of the testing program that we ran. And one thing that I was called attention to is how many people, it's not just how many tests, but how many people were involved in this, and to set up these kind of, bubble campuses, obviously of the players, coaches, and staff, but then, there's transportation, there's refs, there's media, there's the huge hotel staff. And so there ended up being really 6,000 people who were approximately who were part of this program. Not all of them certainly were tested every day, far from it, but that was the overall approach. Working with two of the large diagnostic lab companies, BioReference Labs and Quest. BioReference Labs was really our primary lab in Orlando. They had one of their big facilities in Florida. We worked with them to bring new instruments into that facility so that we weren't taking away from the capacity in Florida at that lab, particularly in that time. And then we spent a lot of time on the right here with point of care providers, which I think are really interesting going forward, not just for sports leagues, but for others. And certainly hope to see more of those out in the marketplace. These are different tests ranging from Q, which is an isothermal amplification test, to MESA and VISB, our PCR tests, Quidel's an antigen test, and then Cepheid is sort of the only longer, well, Quidel too, but Cepheid has had rapid PCR tests for a long time. Those were not something we could regularly access because they're appropriately prioritized for hospital settings. But there were a few cases where we did run those at Advent at the local hospital, and they're very few. But that's a great test because it's a rapid test that also gives you a cycle threshold. And then the other two things I want to talk about, from the beginning of our testing program, we knew we were going to need a lot of testing. So it was important to us to have a comprehensive program, both a community element, which we executed upon in team markets. In Orlando, there was a trailer where the public could go get, free COVID testing. We donated some of these Q Health rapid tests to Florida Health. I think they were the first public health department in the country that had that kind of test, which we were really pleased to contribute to. And then research as well. You see a string of institutions along the bottom. We've done work with these with test manufacturers, with the FDA. I think probably the one that was described most publicly was the work with Yale. They developed a saliva test that is able to maintain sensitivity while skipping some of the expensive and supply chain constrained processes called Saliva Direct. So that was something we're excited to be a part of, and have several research initiatives continuing to go on there. Wanted to also talk about, just to get into a little bit of this, we had all this data from all this testing, but it's really not enough to collect it. We need to analyze it in real time, look at subpopulations, and actively manage the testing program. And I think this speaks to some of the challenges for schools and other settings where they don't have the kind of ability to clinically manage the cases like that. I think that would be something, if I were advising schools and others, I would really, to the extent they can have more clinical management of that's helpful. And what we found, for an emerging infectious disease, for emerging diagnostic technologies, we really needed kind of to go off real world evidence that we were creating. And so, working with the epidemiology group and our medical group, there certainly wasn't a week that went by that we didn't change our protocols, which is, I'm sure, something that those who are doing infection prevention and COVID related work at Stanford are focusing on, that ability to analyze data in real time, make driven decisions on policy changes. And so, you see on the slide here, beyond testing, that went to, physical surroundings, practical contact tracing, how rooms are set up to promote distancing, and on contact tracing, that was a major effort as well, both traditional contact tracing, with interviews, and then we also used some technology, some digital chips that people wore that tracked the time of interactions they had with other people. On the testing side, the PCR instruments that we used provided a cycle threshold, which helped us understand how much of the virus is in the sample. That's something I know that in the past has probably been more of interest to the scientific community than clinicians, but I think we saw in the clinicians who are advising us a change maybe in views on that, and I think there's some change in views on that with COVID in general, or some broader recognition of how important cycle thresholds can be to clinical management. So the population we were looking at was primarily a young, healthy population, but there were individuals among Disney staff and transportation drivers, for example, who had COVID and recovered and weren't always in that younger group. And as they were going through the program, there was continuous discussion about the lessons we learned from testing and seeing those positives and cycle thresholds. So there's two papers that are one here on the left is kind of in the works, and the one on the right is up as a preprint. I'll talk about those just for a couple minutes. So really the first one here, we learned early on that it's important to distribute a population of people who may test positive into two groups. One is individuals who are recovered from a SARS-CoV-2 infection, and the second is individuals with an acute infection. And so to do that, in addition to trying to get as much history as we could, we did some serology testing. And I think the key takeaway on the ideas of these groups is that there are persistent, and this is now more well described. It was described a little bit this summer, but maybe less so. These persistent positive individuals who experienced negative PCR test following clinical recovery prior to additional positive tests, and we had approximately 50% positive on a daily PCR at least once after more than 30 days after their initial infection. And so that for people who recovered quite frequently, more than half, they would still occasionally test positive more than a month after. And that's what this slide is showing. The red X's being positive tests, the blue on the left the initial infection, and then the gray these negatives, and you can see some of these periods of negativity for significant lengths before other positive tests. So what we observed here, and we're going to publish on this, is that the intermittent detectable period for the virus for us in our work was up to 68 days, a mean of 31 days. Our period didn't extend past past 90 days for most individuals, and so it's a caveat there. And then on average, seeing the cycle thresholds, getting some sense that these were high cycle threshold, i.e., low viral load positives. The persistent positives had a mean cycle threshold of 34.1, which is quite high, versus an acute infection who had a mean of that 30.84 and a range down to 21 in this ambulatory population. So we're going to be publishing some of that data. The second paper I just wanted to speak to briefly, and I'll get out of my technical depth here for sure, but I just want to call attention to it because I think it's some important work, and it's something we were really pleased to contribute to. So this is up in a preprint now, and focusing on really the viral dynamics of SARS-CoV-2 infection and the predictive value of repeat testing. And because we had this group of people who were bus drivers, livery drivers, Disney workers who were living out in the community, and we also had some data from pre-Orlando when players and team staff were in their markets sort of getting ready. We observed infections among people who had been testing negative, each day, and then would become positive, and we'd see the beginning of the trajectory of that virus before they, typically someone gets a test when they're symptomatic or they think they have an exposure, and you're not picking it up on that first day that it's detectable by PCR. So that was the idea here, and this this relates to some work that many of you are probably familiar with. Daniel Lerbour and Michael Minna, among others, have published on this and discussed at length sort of frequent rapid testing with less sensitive tests being more valuable than less frequent testing with more sensitive tests. And so there's an emerging literature on the importance of being able to provide higher amounts of testing and being accepting of those tests being lower sensitivity, particularly if they can turn rapid results. So for this study, we essentially, the research group that we worked with, we were able to estimate the full viral trajectory from the beginning. So that included really getting the clinical sample, getting the raw data, and fitting that to a model where they identified a proliferation phase and a clearance phase, and were able to distinguish between acute and persistent infection and between that proliferation and clearance phase. So this is among 68 individuals who either tested positive prior to Orlando or were among those vendors living at home in Orlando. 46 had acute infection, 13 had reported symptoms, and really, the quantitative data here can inform clinical and public health decision making, and we've gotten some really nice outreach on this work. And essentially, by using the CT value, I mean, first on the left here, you can see the day from the time from being undetectable to being at peak viral load was the mean was really 3 days, and it was observed as little as 1 or 2 days. And so, it speaks to that potential need for frequent testing. And then by using the CT value on the right, they were able, their group was able to estimate whether, because they can estimate whether an individual is in that clearance or proliferation phase. With a second test after a first test, the ability to estimate that increased dramatically, because you can see the cycle threshold change from one test to the next. And so that's potentially meaningful, in the clinical setting for trying to figure out, what stage in an infection someone is. And so, again, this is something we're now trying to build models based on understanding sort of a better sense of the viral kinetics, how that could be used to build better testing models. How frequent does a surveillance screening program really need to operate, and how can you tie frequency to sensitivity, and what might you expect that will actually yield in terms of results, things like that. So this is a piece of that literature around frequent testing. So just want to, before I wrap up, just want to point out, again, I think we're sort of always cognizant of, that we're fortunate to be an organization that have a lot of resources, and there are huge efforts, throughout all of this to really focus on community work. This is our MBA Together page. Public health messaging. Lots of work with teams on racial injustice, on voting, and really trying to think about our restart as something that was a larger platform than just playing basketball. But how do we talk about public health? How do we talk about civic engagement? And so that was a really important part of this for us, certainly for the players, to have that platform in Orlando. And I think they exercised it incredibly well. And then just the last thing, thinking about next steps for the NBA. Obviously, the state of coronavirus in the country is a difficult one right now. Our goal is to play this year in 30 markets, and to do it in front of a limited number of fans. If there are safe ways to do that, I think we're given our medical group, we're likely to be a little bit more conservative maybe than some of the other sports that have operated in terms of looking at fan testing and looking at some other things. And so that's going to be part of it. And then figuring out the initial piece is just how do we even, is there a way to safely play outside of a bubble right now? We think there is. We think that for better or worse, that this experience really brought home to players and staff around the league the importance of not just testing, but how to behavioral protocols, distancing, masking, hygiene, all of those things. And so we know there's a lot of desire to play, and we're working to figure out how to do that in a way that's safe, and to continue to support some of these public health awareness efforts that we've been doing. So I'll stop there. I want to make sure to leave time for questions, and I know that was a lot, but hope it was interesting and a little different. And thanks again to Kevin for inviting me, and to Dean for the work in terms of being one of our advisors. We could not have gotten to this point and be looking ahead to next season without that medical and scientific expertise along the way.
David, thank you for that. It's no surprise you guys are so successful looking at really the professional and just amazing way this whole. I couldn't believe all the stuff that was done so professionally. It looked like took years to set up, and obviously clearly didn't. So congratulations again. I have a number of questions coming in, and again, Dr. Schulman and Dr. Winslow on the panelist group of this as well. I'm going to both ask them to comment at some point whenever they'd like to. But I also have a few questions for you. I'd probably like to get into that. I have actually perhaps Dr. Upi Singh, who's our division chief of infectious disease here at Stanford, I wanted to ask a question. She's on the panelist there, so I asked her if she wouldn't mind asking it live.
Hi, David. Congratulations. That was a great presentation and wonderful to see all the work that was done behind the scenes. I'm wondering if you can talk about cost per person in the bubbles. So what did all of this take? And I want to include hopefully like the staffing and not just the players. I think it would be important for us to sort of understand the scale at which this had to happen. Thanks.
Yeah, great question. And I'm sorry, I can't get into the specific, I just don't have the specific cost numbers. Thankfully, that's someone else's job. But, I think publicly reported, there's reports of, 150 million. I think those are in the ballpark for all of these operations. And so, I mean, incredibly expensive. And I think we want to be, very cognizant again of the fact that this is a pretty unique environment, both in terms of a workforce that has to be unmasked and in direct physical contact. As we've thought about other analogous workforces, there really aren't very many like that. Other than sports and sort of live entertainment or taped entertainment production, there's just not that many workforces like that. And so, and the percentage of our revenue that can be derived from putting on, these kind of products essentially for television and digital media, it made sense. But I think it's important to acknowledge that this doesn't make sense for a lot of operations. And rather than trying to repeat it, it's what lessons can we tease out about how effective masking and distancing can be, trying to use some of the data we collected because we were doing daily testing to learn more about, viral kinetics and what kind of testing programs for a school, would be sufficient versus what ones, even if it's an inconvenient truth, might not be. And so I think that's really, how we've tried to think about it with our, and thankfully we have good public health advisors who continue to challenge us to, really think about how we can contribute there. But it was, hugely expensive, even for a well-resourced organization like ours. And I think it's why, you haven't seen a lot of other organizations, although, again, interesting to us that we had identified before we then saw them turn to bubbles, sort of entertainment production, who has also turned to those kind of, significant bubbles, because it's sort of the best guarantee if you're trying to get people together and they can't wear masks and they need to be, without distance.
I think the social media outreach, especially to young people, is a real obligation. And I know that the NBA did that. And certainly for teenagers and other young people to sort of talk about masking and distancing and the importance of it. And I remember some of the videos with Tony Fauci and some of the basketball players. I think that's, it's great to see you guys doing that. And I think that's going to be even important moving forward, just because we're all getting tired of this. And I think to sort of keep reemphasizing that messaging by people who, young kids or young people look up to, I think that's going to be really important. So thank you.
Thanks.
Thanks so much, Dr. Singh. Dr. Harrington, I was going to say earlier, it was almost a perfect NBA season, but only almost, because the Warriors weren't the one winning this season. I see you have the Boston Celtics in the background. Sorry that the Lakers now have tied them for the most championships. I think you had a question as well.
Yeah, I do have a question. First off, David, thanks for joining us. That was a fascinating mix of good old-fashioned public health and the operational efficiency of the NBA. It's really impressive. Congratulations. My question is something that Upi brought up at the end about getting tired, and you made reference to mental health early as you were talking about the medical facilities. One of the things that we see, I'm even including amongst our residents, our fellows who are not able to have social interaction like they had been having. Any insights from, this is a group of young people really isolated for 3 months. Any insights on the mental health issues that maybe be more generalizable to other populations?
Yeah, so I mean, they were real, and fortunately, mental health is an area that's been a focus of ours for a number of years, and so we kind of knew going into this, and we had resources we can draw on. We didn't have to build it up from scratch, but I think even though there were certain aspects of the bubble, and I was there 12 weeks, and have 2 young kids who weren't there, so I certainly experienced this too. There were certain aspects that were less challenging from a mental health standpoint, insofar as you knew that people there weren't testing positive, and there was a degree of comfort that came. As someone managing the health side, it was my challenge to keep piercing that comfort and trying to forcing people to stay vigilant. But the monotony was real there, like it is for a lot of people in a lot of places, and just the again, I want to be very self-aware of like, how fortunate everyone was there to be at a resort, but it is still the same thing every day for 3 months. And, you see, players and staff, and doing it myself, FaceTiming, your kids for weeks and weeks and weeks, the way a lot of people have to do with their parents now. It was really, it was a real challenge. And so our psychologists were busy. They were particularly busy during some of the social justice, acts and protests and awareness campaigns, and people feeling like they were trapped there and they couldn't be part of their communities, and they wanted to be, out protesting and doing things. And I think finding different ways to connect, and really trying to be creative about, like we can't change the background. Like we were not in this bubble because we want to be, but what activities, how do we set up outdoor movie nights? How do we set up distance yoga class? How do we do fun different things with food, and just even like little things like that, and just trying to get people to pause and connect even from a distanced way. And frankly, like we were focused, it's not practical everywhere, but on taking it a little bit off Zoom. I like a lot of people, I feel like I spend my life on Zoom now, and trying to get some of those distanced but personal interactions, I think made a big difference. And then just having the mental health resources available, because they were really necessary.
Great. David, I'd like to jump over to some of we have a number of questions popping up here. I'm just going to read out a few of them. Dr. Lowe asks, did they encounter any pushback with respect to privacy and electronic tracking? Do you know of any efforts to apply this approach to the general population?
Yeah, so I don't know, pushback. I mean, I think we all had a healthy conversation with the Players Association. I mean, a good thing is that, our players have, great representation in the Players Association. And, we've focused on privacy issues with them for years around health records and wearables data and things like that. And so we had a foundation again to start from. I think, people were a little bit more willing to say, look, like we've, people had just spent the last, 1 to 2 months, at lockdown at home, and they said, we get it. Like this is a little different now. Whether people who will be outside of this kind of environment where there's a baseline level of trust, where, how generalizable that is, I don't know, but I think we did see people willing to say, look, like we understand these are unprecedented times, and while we still care about privacy, we have to try to manage to the times. In terms of other efforts like this, yeah, I mean, I do like when we think about our arenas next year, for example, and how might you test fans? You can't hold mass testing events where you get rapid testing back. So we're looking at solutions that are there are different companies out there that do test aggregation and verification. So integrating with the big diagnostic labs, big medical centers, at-home testing companies, Let's Get Checked, Everlywell, companies like that, and then can validate positive or negative test results. And it's like one example, I know the Partnership for the City of New York, which is a economic development group in New York City, is working with Clear, which is the airport fast lane company, who has a product called Health Pass, where they have a combination of a symptom survey and a temperature check and some of that testing integration. And so you can certify the same way you used, that traditionally you'd certify that you're you and you have a plane ticket and your identity documents for Clear at an airport, that you have the necessary health documents based on whatever business rules a business in. And they're trying to create kind of a zone in Midtown of certain businesses who are part of that network. So, and I know obviously some of the Apple and Google, contact tracing work that's going on as well. So those are some of the efforts I'm aware of.
Got it. Thank you. Another question here. What percentage of positive tested patients became ill? How many were critically ill of the ones who were positive?
Yeah, so on the players and team staff, I think you said it, but I probably should have gone into that more. We didn't have any positive tests among players and team staff in Orlando. Now, prior to Orlando, we did. People were living at home in their markets, and we didn't have any. We haven't had any any NBA staff like that become critically ill. Fortunately for our players, it's a young, very, very young, very healthy population. We on the Disney staff and bus drivers, we don't have as good data on that, because our job was, we would get their test and then we would make sure that they were being managed by their primary care physician, but they weren't living there. They were kind of going to work, and we weren't managing all of those cases. So I don't have as much data on that.
Okay, no problem. Moving on to another question. This is a good one. Matt Messias asks, early in the pandemic, there was some variability of how seriously players took infection risk, things like Rudy Gobert and Lou Williams. There seems to be less of that as soon as the bubble was created. Was that really you guys doing the education, doing that cultural change? Was it just kind of the change in culture from everything going on? And if it was from you guys, what things were you doing that were effective?
Yeah, I think it was a part, I mean, I think we were fortunate that we had a real partnership in leadership at the top. So among, our commissioner, Adam Silver, and the executive director of the Players Association, Michelle Roberts, and the president of the Players Association, Chris Paul, and sort of, unlike, unfortunately, other efforts that we've seen around the country where there may be like mixed messaging from different groups of leadership, we had a really consistent message from the top on, both sides, such as it is, right? And it wasn't sides. It was like, everyone's goal is to keep everybody safe. Here's how we're going to do it. No one likes any of this, but this is what we have to do. And then, as I said, we have some people, in my group, 2 people with public health backgrounds, and really just, endless messaging on that. And then I think it was just inescapable to know, you were in a bubble, you were living away from your family, and it just like you couldn't lose sight of that. You had to get tested every day and fill out symptom maps and all those little kind of nudges and cues that this is not normal and we have to stay vigilant, were a big part of it.
Gotcha. Dr. Marin asked, did you anticipate and will you track a surge of infections in players since leaving the bubble? So were players tracked after they left the bubble?
Players who are working out at team facilities are still being tested, and we've had some positives and more recently, but not certainly, I wouldn't say a surge. I think when our players and staff are living at home, there's some amount of correlation just with what's going on in those communities. It does seem like maybe because of the education and testing, we generally have lower rates of infection than in those communities. But at the same time, players and, NBA players can be 19, 20 years old and are in a lot of ways different, in a lot of ways the same as a lot of 19 and 20-year-olds, and focusing people who are at substantially less risk from this virus on still taking it seriously, because there is a randomness to it and there's a community element to it that's really important. So focusing on those kind of that kind of messaging, and that's what we're going to have to do as we get into our next season if we're not going to be in this kind of bubble again.
Got it. Dr. Weinberg asks, in terms of extending what you learned to the entire society, what differences were observed between the need of players or staff and the acceptance of public health measures? So again, that question of, these patients single versus married versus those with children, variations in race or whether the political nature. Was there any anger, resentment when players got infected initially, like Rudy, and the cost of the program? So a lot of good questions. There's a lot of questions in there, but anything else? And this was touched on a little bit earlier, but that you learned from this that can be generalizable to the public?
I don't want to go back to the answer I just gave, but I do think that kind of consistent, strong messaging and one thing that was nice about being in this bubble was figuring out how to create community and making people feel like it's not just for them and they're part of a community. I mean, that's a really hard problem that I assume has been a big part of public health for a long time. But one thing that was good about being in the same place is it was an inescapable fact that you were part of the same community, right? You weren't 30 NBA teams all over the country. It was the only time the NBA has never been together in one place, that long, not even close. And so creating that kind of community value and, seeing, team staff and players like telling other people to put their masks on and things like that. You start to see some of those kind of, multiplicative benefits from a public health standpoint. So I think, just thinking about it's sort of basic public health in a way is, that sense of a community, the education, the consistent, clear leadership. And obviously we had to put a lot of bells and whistles on that given what we were trying to do. But I think the foundation is in, public health principles that we all know and just, need to get a little bit better at as a country and, figuring those out.
Gotcha. Before I'm going to jump over to Nigam Shah in a moment, one more quick question up here from the list. One question just asked, how many, with so many tests being done, were there any false positives and how were those investigated? And a comment, thanks for the great presentation.
Yeah, it's a great question. That one to get really into, I could go through a whole nother slide presentation on that. So yes, there were false positives absolutely. And I think that's a real, not a lot, but enough, 1 or 2 per thousand, that we had, whole protocols to deal with those, to quickly rerun them, to do orthogonal testing where they were tested on other instruments. And because our advisors had been focused on that and had helped us set up those protocols from the beginning, we were able to avoid players missing games while inconclusive results were kind of being analyzed. But I think that's a really complicated problem for surveillance programs in a setting where there's less ability to put clinical resources at it. And it speaks a little bit to the fact that although maybe some antigen tests aren't, you'd wish they were a little bit more sensitive, that PCR may be overly sensitive for some screening applications. And maybe the perfect test for a lot of screening applications would be sensitive to one infectious unit, right? And so if an infectious unit is 10 to the 5th or something like that, viral copies of SARS-CoV-2, and a PCR instrument can pick up several hundred copies, maybe for a lot of surveillance settings that's too sensitive. Now it's a great diagnostic test for a lot of other purposes, but yeah, I think false positives, when we started, it did seem like there was very little discussion of those, but we experienced them, we managed through them, and I think there is now more recognition of that being need to retest positives if possible. Obviously it's not always possible given the surge right now, but
Great, thank you. I'm going to jump over to Dr. Shaw. I had a question.
Thank you. This was a fabulous feat of operational organization to weave with public health. In all the data that you collected, were you able to sort of tease out the estimate of number needed to test to prevent one infection? Like on top of hand washing, masking and physical distancing, what is the additional incremental value of testing? Sort of a little bit goes to Upi's question around the cost and tests being the most expensive.
Yeah, it's a really good question. I mean, that gets to some of that work. The graphic I showed from the paper from Larimore and Mina speaks a little bit to that. It models out the expected reduction in cases that you would expect from weekly, 3 times weekly, daily testing. We didn't really, I'll talk to our epidemiologist about that. That's actually really interesting. I think because of the unique nature of the setup where we didn't have these positive cases within the bubble, and we only, had them from kind of the vendors who are going home at night and coming in, and we'd get them and, pull them out. I don't think our data really supports good modeling of that. So I know we looked at those theoretical papers. We did some epi modeling of the bubble before we got down there to see like what we might expect and different levers we could pull, and using that kind of modeling that's been done theoretically. I don't know if our data supports doing that practically though.
Thanks so much, David. I want to, before we get close to closing here, Dr. Schulman has been with us, Dr. Winslow. Welcome you guys to make any comments. And again, thank you to both of you for your involvement in this really amazing process. Kevin, I see you're unmuting.
Yeah, just first off, thanks, David, for a great presentation. David just kind of has been talking about all the research that they're doing. When you look at, what really impressed me was how much effort they were putting into the research side of this, and a commitment from the very beginning to make sure that what came out of this was going to be generalizable to the extent it could be. So really want to applaud them. They could have easily have done this, not talked to the research community, not published any of the results. But obviously this was a fantastic natural experiment. Grateful for them sharing it.
Thanks so much, Dr. Schulman. And then Dr. Winslow, as David mentioned earlier, and Upi, happy Veterans Day to you and all our veterans. Perhaps we'll ask you to help us close this out.
Can you hear me okay, Errol? Yeah. So anyway, first of all, David, great presentation. And I was really so happy to see, particularly the viral dynamics data that you presented. Honestly, I had no idea that you were going to be really doing that excellent science, as part of this this effort. One of the things I'd like to just, maybe close with is a shout out to a Stanford School of Medicine graduate that you mentioned briefly at the beginning, Dr. Leroy Sims, your medical director. And again, Leroy was actually one of Dr. Parsonet's advisees when she was the Senior Associate Dean for Medical Education, here at our School of Medicine. And again, Leroy is just an absolutely amazing leader. I think a lot of what we did as sort of the Science Advisory Board was really just validating a lot of what Dr. Sims really already was recommending to the NBA. So it was a real honor to work with him as well as all the other members of the panel. And again, David, thanks so much for asking all of us to participate.
Yeah, thank you. Thank you for your contributions.
Thank you, everybody. Again, David, thank you for joining us today, and congratulations. And everybody, I hope you have a great week, and we'll see you next week. Thanks again so much.
Thank you.
Bye-bye.